Bismillahirrahmanirrahim. Today we will have case quiz number 47. Case data: 77 years old female with 4 months history of persistent right knee and low-grade fever. Right knee pain and low-grade fever for 4 months duration. 3 years ago, she underwent right total knee replacement to treat osteoarthritis. 3 months ago, a synovial fluid aspirate was positive for methicillin-sensitive Staphylococcus aureus with 2,500 leukocytes per microliter. She was treated with intravenous then oral nafcillin without improvement. On examination, temperature was feverish 38, blood pressure within normal 133/77, pulse rate 84 beat per minute, respiratory rate 12 cycle per minute, body mass index 19. There is a vertical well-healed surgical scar across the anterior surface of the right knee. The knee is slightly warm with pain on passive range of motion. Investigations revealed hemoglobin slightly anemic 11.3, white BCs raised 13,000 per microliter with 88% neutrophils, ESR shooting 88, C-reactive protein raised 17 mg per deciliter. Radiographs of the right knee revealed prosthetic loosening and periprosthetic lucency of the femur. Radiographs of the right knee revealed prosthetic loosening and periprosthetic lucency of the femur. And lastly, a repeat synovial fluid aspiration confirmed the presence of methicillin-sensitive Staphylococcus aureus. So, which of the following is the most appropriate next step in the management? What to do next for this patient in order to treat her case? Do we need to add diclofenac, to add rifampin, to add intravenous vancomycin, or surgical removal of the prosthetic joint? This is a case of infected prosthetic joint with Staphylococcus aureus and not responding to intravenous followed by oral antibiotics. So the most appropriate next step is surgical removal of the prosthetic joint. Infected prosthetic joint. This patient has a prosthetic knee joint infection caused by methicillin-sensitive Staphylococcus aureus and so requires surgical removal of the prosthesis. Prosthetic joint may become infected later after implantation after 3 months up to several years by a homogeneous spread of the organism or by delayed response to low-intensity pathogen. The joint may be swollen and inflamed or only painful. Leukocytic count may be only moderately elevated or modestly elevated. Erythrocyte limitation rate ESR and C-reactive protein are usually elevated, so we don't need here shooting or very high white BC count. Just modest elevation with predominance of neutrophils is diagnostic or suggestive for infected prosthetic joint. Radiographs may reveal erosion or loosening around the implantation site. Diagnosis requires synovial fluid aspiration or open debridement along with gram stain and cultures. Treatment of prosthetic joint infection typically involves removal of the infected prosthesis. This patient findings including joint pain and elevated leukocytic count ESR and CRP level, along with positive synovial fluid cultures, prosthetic loosening, and periprosthetic bone erosions are consistent with prosthetic joint infection. Antibiotic use may be reasonable, and an infection occurring early late after implantation may be sufficient. However, this patient has already not responded to antibiotic treatment and therefore require removal of the prosthetic knee joint. After removal, an antibiotic spacer is inserted and long-term weeks to months antibiotic therapy is indicated. Only after complete resolution of the infection, new re-implantation or re-implantation can be considered. Diclofenac is potentially useful therapy for joint pain but doesn't address the prosthetic joint infection. Some evidence suggests that rifampin may improve outcome in patients with methicillin-sensitive Staphylococcus aureus prosthetic joint infection who undergo early extensive surgical debridement. However, this patient didn't undergo debridement, and there is no indication for use of rifampin in this particular patient. Intravenous vancomycin is useful for infection with methicillin-resistant Staphylococcus aureus. However, this patient's infection should be sensitive to nafcillin or oxacillin along with joint removal, and no additional benefit for vancomycin would be expected. The key points here is treatment of delayed onset prosthetic joint infection typically involve removal of the infected prosthesis. This is an orthopedic case, not rheumatology, but may be faced in rheumatology clinic. So we brought this case here in rheumatology case quiz, although it is not a rheumatology case. And finally, thank you very much for your attendance, and we will meet tomorrow with case quiz number 48. Wassalamu alaikum wa rahmatullahi wa barakatuh.